You've spent your whole life believing that when a doctor recommends surgery, it's because you need it. That signing that consent form is just a formality on the road to getting better. I used to believe that too. Then I started paying attention to the people who went in for what they were told was a routine procedure and came out different. A man who walked in with a bad back and left unable to walk at all. A woman who survived her heart surgery but lost a year of her life to complications nobody warned her about. A retired teacher who went in for a knee replacement and spent 6 months fighting infections that nearly killed her. Here's the truth nobody tells you until it's too late. The older your body gets, the more the operation itself becomes the enemy. Not the disease, the operation. I'm Dr. John Myers, and I've spent over 2 decades on both sides of the operating table. Today, I'm going to show you the hidden reality behind 5 common surgeries recommended for people over 60. Surgeries that carry risks your surgeon might not have time to explain in a 12-minute appointment. This isn't about fear. It's about walking into that consultation room with your eyes wide open, armed with the questions that separate the informed patient from the vulnerable one. Because if you're over 60, you deserve more than a doctor's signature on a clipboard. You deserve a fighting chance to live longer, stronger, and on your own terms. Let's start with a question. If you took a brand new car and a car with 200,000 miles and put them through the same grueling race, would you expect the same result? Of course not. And yet, for decades, medicine treated a 70-year-old body the same way it treated a 40-year-old one. Same protocols, same recovery timelines. That's finally starting to change, but not fast enough. Here's what happens when an older body goes under general anesthesia. The heart pumps harder. The lungs clear anesthetics slower. The kidneys process medications less efficiently. And the brain, this one surprises people, becomes temporarily disoriented in ways that can last weeks or months. Doctors call it post-operative cognitive dysfunction, and in patients over 70, it happens far more often than anyone admits. I remember Eleanor. She was 74, sharp as a tack, ran a small business from her kitchen. She went in for routine gallbladder surgery. When she came out, she didn't recognize her own daughter for 3 weeks. The surgery was technically flawless, but Eleanor never quite returned to who she was before. Age alone isn't a reason to avoid surgery. I've operated on 80-year-olds who bounced back faster than some 50-year-olds. Age is just a number, but frailty is not. Frailty is a medical term. It means your body's reserve, its ability to withstand stress and recover, has dropped below a critical threshold. Roughly 40% of people over 75 show signs of frailty, nearly 60% over 85. The question isn't whether you can survive the operation, it's whether you can survive the recovery. Those are profoundly different things. Surgery number 1. Open heart surgery in frail patients. Coronary artery bypass grafting is one of the most common major surgeries on older adults. The idea is simple. Blocked arteries reroute the blood flow. For the right patient, it works beautifully. But here's what the brochure doesn't show you. Open heart surgery requires stopping your heart completely. We put you on a bypass machine that does the work of your heart and lungs while we operate. For a 60-year-old in good shape, that's manageable. For a 78-year-old with kidney disease, diabetes, and cognitive decline, that bypass machine is an assault on every organ simultaneously. Studies show that in frail elderly patients, open heart surgery carries a 30 to 40% risk of major complications: stroke, kidney failure, prolonged confusion, extended ventilator time. And up to 15% of high-risk elderly patients don't survive the first 30 days after this surgery. What's the alternative? In many cases, TAVI, a catheter-based procedure that replaces the heart valve without opening the chest or stopping the heart. Less dramatic, far kinder to a body that needs kindness. Does this mean refuse heart surgery? Absolutely not. It means ask your surgeon, am I a candidate for a less invasive approach? That single question could change everything. Surgery number 2. Aggressive spinal surgery. Back pain in your 60s and 70s is almost universal. The solution offered more and more often is spinal fusion, hardware inserted up and down the spine. Some spinal surgeries are absolutely necessary. If a spinal cord is compressed to the point of paralysis, that needs immediate intervention. But elective spinal fusion for chronic back pain in an elderly patient? The evidence is troubling. A major study in the journal Spine found that in patients over 65, complex spinal fusion had a complication rate exceeding 40%. Blood clots, deep infections, hardware failure, and adjacent segment disease, where the vertebrae above and below the fusion break down because your spine's mechanics have been permanently altered. And here's what frustrates me most. Studies show that for many elderly patients, aggressive surgery provides no better long-term pain relief than physical therapy and targeted injections. No better, but with dramatically higher risk. A brilliant spine surgeon once told me, sometimes the best operation is the one you don't do. Surgery number 3. Major cancer resections. This is the hardest to talk about. When someone hears cancer, the instinct is immediate. Cut it out. I understand that completely. But here's what 2 decades in surgery has taught me. The goal isn't just to remove the tumor. It's to give the patient more good years of life. And sometimes, not always, major surgery in a frail elderly patient does the opposite. Take the Whipple procedure for pancreatic cancer. We remove the head of the pancreas, part of the small intestine, the gallbladder, part of the bile duct. 6 to 10 hours of surgery. In younger, healthy patients, it can be life-saving. In an 80-year-old with heart disease and reduced kidney function, the surgery may technically succeed, the tumor is gone, and the patient still passes away within weeks from surgical complications. Not from cancer, from the operation. This is called futile surgery, and it's more common than anyone admits. A landmark study found that nearly 1 in 5 elderly cancer patients who underwent major resection experienced failure to rescue, a complication their weakened body simply couldn't survive. Ask your oncologist directly. If we don't operate, what does watchful waiting, radiation, or targeted therapy look like for someone my age and health status? That question opens a door many patients never knew existed. I had a patient named Robert. He was 76, diagnosed with slow-growing prostate cancer. 3 doctors recommended immediate surgery. But Robert was a researcher. He asked about watchful waiting, radiation, hormone therapy. Eventually, they agreed on monitoring with regular checkups. That was 6 years ago. Robert is still alive, still healthy, never had surgery, and is enjoying retirement with his wife. Surgery number 4. Elective joint replacement in patients with multiple health conditions. Hip and knee replacements are among the most successful surgeries ever developed. For the right patient, a new hip transforms quality of life. But here's where it gets complicated. Elective means you have time to think, time to prepare, time to ask whether this is the right moment for your specific body. In patients over 75 with 3 or more serious health conditions, heart disease, diabetes, chronic kidney disease, obesity, elective joint replacement carries significantly elevated risks. Blood clots are the biggest danger. Deep vein thrombosis can travel to the lungs and become a life-threatening pulmonary embolism. Add post-operative pneumonia. Add hospital-acquired infections. The question isn't, should I ever have a joint replacement? It's, is my body in the best possible condition right now? Optimizing blood pressure, blood sugar, weight, and cardiovascular health before surgery can reduce complication rates dramatically. Some hospitals now require prehabilitation before they'll schedule these operations. Most people have never even heard that word, and they absolutely should. Surgery number 5. Emergency abdominal surgery. This one is different because you don't choose it. It chooses you. A perforated bowel, a ruptured appendix, internal bleeding. These situations don't wait for a calm conversation. But knowing the risks in advance changes how families make decisions in those terrifying moments. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates, 30 to 50% in the most severe cases. Not because surgeons are unskilled, but because an elderly body under sudden trauma fights on too many fronts at once. So what can you do? 2 things. First, don't ignore abdominal symptoms. Persistent pain, bloating, changes in bowel habits. Catching problems early means treating them before they become emergencies. Second, have the conversation with your family now, not in the hospital corridor at midnight. What are your wishes if emergency surgery is the only option? Now, let's talk about what you actually do with this knowledge. Before any major surgery, there are 4 questions every patient over 60 should ask. 1. What happens if I don't have this surgery? If the answer is nothing urgent changes in the next 6 to 12 months, you have time. Time to think, get a second opinion, optimize your health. 2. Is there a less invasive alternative? Medicine has changed enormously in the last 15 years. Robotic surgery, endoscopic procedures, catheter-based interventions. Options that didn't exist a decade ago are now available. 3. What does recovery realistically look like for someone my age and health profile? Not the average patient, you. The answer should be specific, not generic. 4. What is your personal complication rate for this procedure in patients over 70? Surgeons track this. A confident, honest surgeon will tell you. If they seem uncomfortable, that itself is information. And here's something most patients never get told. What you do in the 2 to 4 weeks before surgery matters enormously. Surgeons spend years mastering the procedure. Almost nobody spends 2 weeks preparing the body that has to survive it. Prehabilitation. You eat more protein because protein rebuilds tissue, and most people over 60 undereat it. You walk every day because stronger legs and lungs mean faster recovery and fewer blood clots. If you smoke, Even stopping 2 weeks before surgery measurably lowers your risk of complications. The conversation with your anesthesiologist matters too. Bring a complete list of every medication and supplement, including fish oil and herbal sleep aids, because some interact with anesthesia. Ask whether a regional or spinal anesthetic is an option. For many hip and knee operations, it is, and it's gentler on an older brain. If you wear hearing aids or glasses, have them with you until you go under, and back on the moment you wake. Patients who can see and hear when they wake up get confused far less often. Arrange your help before surgery, not after. Clear rugs and cords. Fill prescriptions in advance. The first 72 hours at home set the tone for the entire recovery. Watch for warning signs: sudden confusion, fever, a swollen or painful calf. Any of those, you call immediately. And get the second opinion. A good surgeon expects it. A good surgeon welcomes it, because they'd want one for their own mother. If 2 qualified surgeons looking at the same body land on different recommendations, that's not a problem. That's information. Here are the red flags that tell you to slow down. Speed. You're being rushed onto the schedule. For a planned operation, real urgency is rare. If a knee that's hurt for 10 years suddenly has to be replaced this month, ask why. A single path. Surgery is the only option mentioned. At 70, there's almost always more than one road. Medication, therapy, injections, watchful waiting, a less invasive version. The do-nothing option is never discussed. Doing nothing, watching carefully and treating conservatively, is a legitimate medical choice. If your surgeon won't tell you what happens if you wait, you don't have enough information to consent. How your questions land. You ask about complication rates or alternatives and get a brush off. A good surgeon doesn't get defensive when you ask the very questions they'd ask for their own family. Recovery gets glossed over. "You'll be back on your feet in no time," is a sales line, not a recovery plan. The honest version sounds specific. Here's week 1. Here's when you'll need help. Here's what's genuinely hard. Never go to a major surgical consultation alone. Bring someone with you. The moment you hear a frightening word, cancer, surgery, blockage, a fog comes down. Afterward, you can't remember half of what was discussed. That's not intelligence. It's what fear does to the brain. A second set of ears, a calm advocate who can take notes or record the conversation, someone who can ask the questions if the fog comes down for you. That advocate changes everything. Now, let me tell you about Gerald. 71 years old, retired engineer, sharp as a tack. 3 different surgeons had recommended open-heart surgery. Gerald wasn't afraid of surgery. He was afraid of losing himself. He'd watched his wife go through a major operation and come out confused, exhausted, never quite the same. "Dr. John," he told me, "she went in as my wife and came out as someone I had to take care of." I sat with him for 40 minutes, not 15. Surgery was an option, but so was an aggressive medication protocol combined with cardiac rehab. The data for his specific profile showed comparable 5-year outcomes. He chose the non-surgical path. That was 4 years ago. Last month, he sent me a photograph. He's standing at the top of a hiking trail in Colorado with his 2 granddaughters, grinning like he won the lottery. A surgical recommendation is not a verdict. It is the beginning of a conversation. You are not a passive recipient. You are an active participant. The surgeon holds the scalpel, but you hold the choice. 5 surgeries with serious hidden risks for people over 60. None of this means avoid all surgery. It means be an informed patient. Ask the hard questions. Request the alternatives. Get a second opinion. Your age is not a weakness. It is the accumulation of wisdom and the right to demand better answers. If this helped you think more clearly about a surgical decision, share it. That one share might be the most important thing you do today. Stay curious. Keep advocating for your own health. You deserve a surgeon who explains everything and a medical team that treats you as a partner. One last thing. Everything I've shared is general medical information based on published research and clinical experience. Every person's situation is unique. Before making any decision about surgery, have a full, honest conversation with your own doctor. They know your history. They know your body. And that conversation, informed, direct, and unhurried, is exactly where good medicine begins.